I'm Matt Lallas. I'm one of the epilepsy doctors at Children's Hospital Los Angeles. They have a little bio of me here, which is mostly accurate. I'm born and raised in California. I'm a Los Angeles boy myself. I went to Berkeley for undergrad and then to Chicago for 4 years of medical school, the 4 coldest years of my life. And they were fantastic, and I'm so glad that I did it. I came back to Children's of Los Angeles as my residency for both pediatrics, 2 years, and then neurology, 3 years. And then I went to Miami for officially a 1-year fellowship. There was a second year that was unofficial, and I was really a half-time attending. And then I came back to CHLA because I wanted to advance the care of what we're doing for children with epilepsy there. And I was very fortunate that right before I went to fellowship, Dr. Holder had really gotten started on creating this comprehensive epilepsy program. And that as a result, we had surgical capabilities and we were developing genetic capabilities of a comprehensive genetics clinic in coordination with our Center for Personalized Medicine. But I like to look at the imaging. And that's sort of what I find really most fascinating, partly because I can combine it with the EEG and do some interesting things with that. And that was something that while we had fantastic imaging at CHLA, we didn't yet have anyone who's really combining it with the images. I'll show you one picture of that towards the end of this. My ultimate goal is to get to a point where you guys are asking questions, because I know that this is an Ask the Experts section, okay? But I thought that it was good, because this is understanding your MRI, having just a discussion about what it is we're doing and why. I'm not going to go into the physics of it too much. I'm just going to tell you that an MRI uses magnets. I'm not going to tell you why that's really all that important and what it is that they're doing with the magnet and how it is that they're taking these pictures. I think that's just probably more than we need to today. But I think for a lot of people, looking at an MRI is sort of, the doctor shows it on the screen and says, okay, and here's the problem. And the person goes, oh, yes, I see that. I don't know what I'm looking at. I don't look at brain MRIs, so why would that be of interest to me? You want to know. It is of interest, but it's complex and complicated, and no one really takes you through it. And this won't get you through all of it, but it's just going to be sort of an idea of sort of the basics and an understanding of what it is that we're doing when we look at our MRIs. I have no relevant disclosures, but I always sort of say that sort of thing. Imaging is required in most cases of epilepsy, not all cases of epilepsy. Probably most cases of adult epilepsy. It really is, but there are certain scenarios in pediatric and adolescent and therefore adult epilepsy where you can actually potentially get away from the need for imaging. But the most important questions are why, when, and how. So the why is sort of what are we looking for, right? What am I worried about right now that is the reason that I'm actually ordering this study? Because I have to know, some reason that I'm going to be doing it. And saying that a child has epilepsy is good enough, but it's not necessarily doing the whole part of the process as a physician to just be like, well, they have epilepsy, they need an MRI. I might be more interested in a structure problem like a dysplasia or a malformation, something they were born with. I might be more interested in something new like a tumor or a stroke. I might be looking for changes that occur with time. So maybe that as a disease is getting worse, maybe the brain starts to atrophy and get smaller. I might be looking for consequences of the last seizure. So maybe someone had a seizure and hit their head and they're in the ER not acting normally. Is that because they're postictal? Is that because they might have a bleed? That's not directly related to the seizure, but it's secondary to it, and that might be another reason to get a picture of the brain. Why not is the obvious follow-up question to the why. And the answer is that there are times where we know that the imaging is unlikely to change what we're going to do. And the prototypical example is childhood absence epilepsy. Right? This is a type of epilepsy that almost never has an MRI finding that is actually related to the epilepsy. And so think of getting a study in a child where because they're so young, they're going to move around, you need to sedate them, and now you sedate them, and you get a study knowing in advance that it was unlikely to do anything for that child, and you just gave them all that sedation. So why would we do that? You could just consider the same for juvenile myoclonic epilepsy or for Rolandic epilepsy in most cases. When you have a known defined syndrome, that's pretty obvious. When you don't have a known defined syndrome, then you might be a little more, well, that's not good enough for me. Imaging may not always change the treatment course, and imaging may come with certain risks, and that sort of depends on what kind of imaging you're doing, because different studies have different risks. The when depends on the why. Because if I'm interested in dysplasia or a malformation, something that you were born with, I'm probably not going to be making much in the way of immediate changes to my plan based off that. It might be long-term changes. If, on the other hand, I'm concerned that there's a tumor or an infection or a stroke, that's not something I'm going to be waiting 3 months to find out. That's something I want to know right away. And so the idea of how am I going to change my plan today helps me determine whether or not I need something today or tomorrow or 3 weeks from now or 3 months from now. And that's important because then I get to consider the how. Now, this is a talk on MRI, but a lot of the principles hold true for a CT scan. And a lot of times when parents come to us in clinic, they want to know, why did we do a CT in the ER? They told me it was normal. What does that mean? Or if they haven't gotten any pictures with a CT or an MRI for that first seizure, should they be getting it? Well, why is it okay to wait, 3 months, for the sedation and for all of that? And so we have to have sort of an idea about, well, do I need it sooner? And if I need it sooner, is the MRI the right study? And most of the time, the MRI is the preferred study, because the MRI, unlike the CT, doesn't have any radiation. It uses a large magnet, no radiation from it. Problem is that the MRI takes a lot more time most of the time, at least to see the brain in enough detail that you want. If all I wanted was to know is the brain under pressure, I can do a short MRI, and I don't need to sedate anyone. But if I want to know why they have epilepsy, I need a longer MRI. And a 15-year-old who can cooperate, they'll lie there for an hour and be fine. But a 6-year-old who doesn't understand what's going on, they need sedation. So sedation has its risks. It does give you better and finer pictures than the CT scan for certain things. But the CT scan actually gives you better pictures for calcifications, for bleeds, and it's done much more rapidly. So it's easy to get in a ER if you need it. And if you don't need it, then you don't want it because it does come with a risk of radiation. So in general, those are sort of our two options, and we're going to be talking about the MRI. And the idea is that we're taking this beautiful structure here, this is a brain, and we're taking a bunch of pictures of it. But if you took a picture of me right now, you'd see what you're seeing right now. You wouldn't be able to see the inside. You wouldn't be able to see my liver and my intestines, right? All you'd be able to see is the outside, and that's very limited information. And so what we're doing is we're taking this three-dimensional structure and displaying it on 2D. So how do we do that? We have to slice it. We have to cut it in certain ways, and then we need to have some standards so that one radiologist is going to be comparing the same study to another radiologist. And so we cut it in a few different ways. One is sort of cutting it flat, okay? And that's we call the axial, because it's along an axis. The next way that we can cut it is sort of like this, where we're going from one side to the next, and that's we call sagittal. And the next way is where we cut it this way, and I like to think of that as sort of like cutting it like a loaf of bread. Often how I describe what we're looking at when we're doing cuts, and that's called a coronal. As we cut it into these slices, what we also have to remember is that the number of cuts that we do is going to change how much detail that we have. And so how thick those cuts are is going to make it easier or harder to see things. And we can make it quite thin, but the thinner and more cuts we do, the longer that sequence in the MRI has to be. And then the way that we look at it is to say, well, now that we've done this and we can see all that structure, what does the left look like to the right? Right? We have a way of comparing, we have a way of saying, well, this is one side, does the other side look the same? And if not, which of these two sides is abnormal? And for that, you have to have an understanding of the anatomy. By convention, again, so that one radiologist is going to be looking at it compared to the other radiologist and saying the same thing, the MRIs and imaging on almost every type of imaging modality, they'll put right on the left side of the screen and left on the right side of the screen. And that's what we call the radiologic orientation. And it's based off of the idea of how is the person supposedly lying in the scanner. This is my puppy. He's very cute. He's very cute. There we go. Thank you. I was waiting for a yes, he is. I was waiting for a yes, he is. Thank you. This is my puppy. He's brand new. He's 7 months old. He'll be 8 months. Actually, he's 8 months today. Yeah, he's 8 months today. His name is Stark. This is a picture of Stark. He's named after the family in Game of Thrones. This is him in just a standard photo, right? This is the same photo in black and white. And then this is the same photo, but with a whole bunch of filters and things applied, right? When you take pictures, you are recognizing, hopefully, that you're not necessarily seeing all the data. You're just seeing whatever data that it's being provided to you. And people do fun things with Snapchat filters on their phone. And they like to show things different ways. And sometimes it's about artistry. And it's really still about what you're presenting to the audience. We do something similar with MRI because we have what are called sequences. All right? So when we take a picture of the brain with an MRI, we don't just take one picture. Obviously, I've said we take slices, and so we need 30, 60, 180 pictures in one direction, and then in another direction, and then in another direction. But we also look at them in different ways with sort of different filters applied. They use different protocols. They send the signal and they receive a different signal. And they look at different data. As a result of that, actually, we can learn a lot more about the brain and about what's going on with it, and we can see certain things differently. So this is, that's a battery low side. And I don't know why a calculator popped up. That's interesting. So we have here a flare, an ADC, a DWI, and a GRE, and these are all just different names for sequences, which are actually, in this configuration, better to figure out about stroke than about dysplasia. But as I look at those things, I'm going to be looking for certain patterns to help me make my diagnosis, and maybe no one sequence is good enough. Maybe I need to look at a combination of sequences in order to understand it better. So each sequence provides some of the information, and so what you have to understand is that none of them are truth, right? Because none of them are the whole detail. They're also all calculations. They're all math. And because they're all math, they can adjust the math and make certain things look differently. Or the braces that a kid have might change the magnetic sequences. And as a result, they're not perfect, okay? But they're the best that we got, and they're remarkably good. Then you have to understand the anatomy. And just to quick show it, everyone thinks about the brain as sort of basically two areas, the gray matter and the white matter. And of course, that is the most simplified measurement, but it's an easy way of looking at it first. That on the outside, we have this gray matter, and that's called the cortex. Gray matter occurs in other places that is not cortex. Cortex means bark. That's why it's on the outside. It's like the surface. So that's what's on the outside. Then underneath it, you can see the white matter, which is white on the MRI. And then we have these black spaces in the middle that are called ventricles, and they're fluid-filled spaces. And this is what we're often looking at when we're wondering about pressure. They're supposed to be there, but they're not supposed to be too big. There's a lot more detail to brain anatomy than just cortex, gray matter, white matter, and ventricles, but quick and dirty, easy way of looking at it. And when we look at this on our T1 sequence, it looks like gray is gray, white is white, and fluid is black. It looks different on a T2 sequence. So this is the same picture. Let me rephrase. This is the same area of the brain in I think this actually is a different patient, however. But it's a T2 sequence. It's a different sequence. And now the gray matter looks brighter than the white matter, which looks really dark. And the ventricle looks white. All right? So again, this might only tell me certain things, while the other one might tell me other things. And so looking at them together is very important. On top of that, there's development to the brain. When a newborn is born, they've got all the brain cells that they need. They'll make more white matter cells, but they're not going to make more gray matter cells. But because there's going to be that development in the white matter, because there's going to be those changes, a newborn's brain on MRI doesn't look like an adult's brain on an MRI. And so if you get an MRI in the first month, 6 months, year, you might want to repeat that after 2 years of age. Because after about 2 years of age, it looks to most radiologists kind of like an adult brain. There's still some maturation that needs to occur. There's still some processes that are ongoing. It is still changing. It's changing throughout our lives. But after about 2 years of age, it looks kind of like an adult brain to the radiologist. The computers can tell the difference, but not the radiologist. Then the next thing is sort of the magnet strength, where if you take a look at these two pictures, this one here is of the same patient as this one here, which I'm going to show actually again later. But this one's kind of blurrier and harder to see. And this one's a little better, and that's because this is a stronger magnet. Along with thinner slices, you don't need to have a stronger magnet to have thinner slices, but a stronger magnet can have some clearer images. This is our three-dimensional model of the brain again, right? And it's just a model. But you'll see that there's these grooves and these crests, these sort of hills and valleys, right? And we call the valleys sulci, and we call the crowns, the hills, gyri. And you want to have the right number of them, and it's not that it's something that we like count, but the point is that there should be a normal organization of sulci, gyri, that we can sort of see is predictable from person to person. Everyone has a little bit of variability, but for the most part, most structures show up in a similar way from person to person. This person has an area that I've tried to highlight on the back here in this box, that if you look from the right to the left, right to left, sorry, I'm doing this upside down and reversed, so I wanted to be sure. The colors are not the way they're supposed to be. The white matter in that region doesn't look great, and the gray matter looks a little blurred, and it's all kind of disorganized. And this person has a cortical dysplasia, and has had that since they were born. And did not have epilepsy right when they were born. Epilepsy developed later. And this person has been successfully treated with surgery by removing the cortical dysplasia. But cortical dysplasia is a process where the normal growth that was supposed to occur didn't happen its normal way. It was disorganized. Right? Plasia is a sort of a root for the word, to use the word growth. Right? So dysplasia means it just didn't do it the right way. There's lots of ways to have dysplasia, and there's lots of different malformations that can occur. And there's some things that don't show up right away. And this is one of the things that don't show up right away. If you'll notice on this side, I've put another little handy box. And if you look in that area in the box, a structure called the hippocampus is kind of flattened on the left side compared to on the right. And it also looks a little brighter on the left side compared to on the right. So this is, again, the idea of comparing the two sides and looking at not just the appearance of the grooves and everything, but also how bright, how strong the intensity is. That is called hippocampal sclerosis. And hippocampal sclerosis doesn't show up right away. It's not there right when you're born. It's something that tends to happen over time when people are having lots of seizures coming from the temporal lobe. And it's possible that it's there before we see it, but it's still a process of scarring, essentially, that's ongoing. This is a child who also had hippocampal sclerosis, but if you'll note in that same box, this is a different patient, but it was the same left side, there's also this sort of white area there. And next to that white sort of oblong oval, there's some also off color, a little bit brighter than it should be area. And that was thought to be a tumor. And so we took it out and we found out, no, that wasn't a tumor, thank goodness. This child had hippocampal sclerosis, but they also had a cortical dysplasia next to it. So again, the MRI is only as good as the reader, and sometimes the MRI is limited anyway. And we weren't able to necessarily tell the difference. The good news is that patient has been seizure-free and doesn't have a tumor. Sometimes there are some very slow-growing tumors that can occur associated to dysplasias. So that's where it actually does become tricky, because sometimes you could have a little bit of both. But they're typically not dangerous tumors when it is that condition. You can have dangerous tumors cause epilepsy, but when it's associated to a dysplasia, it's usually something that if it weren't for the seizures, you wouldn't necessarily go and take it out. But if the seizures are ongoing, you would take it out. Contrast. So contrast is something that we put in the body to help highlight changes to the MRI. But we have this really important protection around our brain called the blood-brain barrier. It's there to try and prevent errant bacteria and chemicals from getting into the brain that shouldn't be there. When you have inflammation or tumor or infection, the blood-brain barrier breaks down. It doesn't work as well, and it becomes leaky, and so those sort of things get through. Contrast helps enhance that and helps make that obvious. So the thing that you might be able to see is that there's this white here, white here, white here, sort of in between and kind of around the brain. Now that is not abnormal contrast. That's just because the contrast has to be put into your blood vessels. So right there, it's actually just sort of showing us a little bit of the blood vessels. But it can be helpful, in this case, of a tumor to really show kind of active areas. And then outside of that is a little more suggestive of inflammation and irritability, not actually necessarily the tumor cells, although in this case, the tumor may be going beyond just the contrast. This is not a tumor. This has a few different things going on with it, but this is a vascular abnormality. And along the outside of it, it's kind of dark. And then on the inside, it's kind of this multicolored thing. And that's because the blood vessels are doing a variety of directions and twists and turns and convoluted. Okay? The outside of it, where it's dark, is because of calcium. So we can tell that there's been bleeds there before, and that blood has gotten there, and it's broken down. Actually, that's probably hemosiderin, which is an iron-based blood breakdown pattern, but it could be calcium as well. It died. The computer. Patient is alive. No, it's too far away. It won't make much of a difference. I don't get to show all the pictures. The point being made here is that the MRI is an important tool, and it can tell us many, many different things. But it doesn't tell us everything, and you have to look at it different ways. And as I mentioned, there's these different sequences that I likened to filters that can be done differently for each patient, and it's important to have protocols in place. So what I need for a patient who I'm suspecting an acute stroke might be different than what I need for a patient where I'm trying to diagnose chronic epilepsy. As a result, we have an epilepsy protocol, and we may have a stroke protocol, and we may look at different things, and each one may require a different amount of times in the scanner. Because as we take one picture, we can't just convert that into another. We have to take each sequence separately. So the more sequences you need and the more images in the sequence you need, the more time in the scanner. The more time sitting there trying to be very, very still, which is not problematic for the patient unless they need to be sedated or unless they're claustrophobic. And so the downside is typically that. The contrast, we don't typically think of as dangerous, but there is evidence that it hangs around. So maybe if we're getting too many and too many and too many, maybe it could be. We don't tend to think of it as dangerous in any way. The images that we're getting here show us the structure of the brain. And they show it based off of only the type of sequences that we've asked for. There's still other data that could exist out there that we don't have if it wasn't done. But it doesn't tell us the function. That's what an EEG does. Right? An EEG is telling us about function. And as we look at the EEG, we can see that, even though the brain looked fine on the picture, we have these abnormalities called spikes, or we have areas that are flatter than they should be, where there's not quite enough variability and differences in frequencies as there should be. And that's coming from the right temporal. And we need to be looking there because maybe the MRI doesn't show you what you're looking for. Sometimes the MRI is negative, but you still have one area of brain that's causing the seizures. So an EEG is a function test, an MRI is a structure test, except when it's not. Because there is such a thing as a functional MRI. Now, what a functional MRI is usually doing, basically in clinical application as opposed to research, is you lie in the machine and they show you a sentence, and they have you come up with a verb. or name a picture, or follow along with something, or tap your finger, or whatnot. And compared to when you're resting versus when you're doing that, they take that data and they subtract it. Right? Now, it's not as simple as just doing one picture here, one picture there. You need a lot of pictures in the different categories. But when they have that, and you're going like this versus not, and now like this versus not, and they're taking a bunch of those pictures, what ends up happening is that the brain area being involved in that needs a little more oxygen. And so we're monitoring the change in oxygen flow. And we correlate that and say, there's more oxygen being used during this in this region than when the patient is just resting. And so we're able to test a surrogate for brain function. Right? It's not perfect. It's pretty good. It requires really good cooperation. And there have been people who are doing, mostly on research, again, not mostly clinical, something called resting state fMRI, where instead of needing to do a specific task, like thinking of a noun or thinking of a verb or tapping your finger or whatnot, they just want you to just lie there and be quiet. And they actually do correlation and figure out which regions are connected to each other. And with that, there's some good evidence that we can start finding the normal connections and the normal brain networks for motor control and language control and vision and whatnot. And it's great, except it hasn't yet gone typically past the research phase and into really the clinical. It is something that maybe one day we're going to be moving more towards the clinical, but as we keep doing all these things, we end up finding that it's very dependent upon how skilled the person is in understanding the data in order to create the result. Much easier to understand when it's as simple as I'm doing this for a while and I'm not doing this now and I'm just subtracting that, versus when we're creating widespread networks and having to interpret, is this a normal network versus an abnormal network? So that's something that's probably coming, and more people are doing it. But again, most of the time it's being used more in a research phase than in a true clinical phase. So that's the idea that the MRI as a structure test can be a functional test, but when do we do that? Mostly when we're prepping for epilepsy surgery. Because the rest of the time, if we're not about to go in and potentially alter the connections in the brain by doing a surgery on the brain, we don't really need to take control of that area, so we're not messing with it, so we don't need that. We don't need to put them in the scanner and find it. But if we're prepping for epilepsy surgery and we want to leave all those things intact, then we need to know where that is. And so there's times where testing is not needed. There's times where testing can be done, but doesn't necessarily benefit the patient, as I've said. And then there's other times where it can actually harm the patient, and I don't mean the radiation. So let's say that I had that patient with childhood absence epilepsy, and they were fine. They were responding to medication. They had the normal EEG findings. Again, childhood absence epilepsy almost never has any findings that are associated to actually that problem. But that doesn't mean you can't have some finding. All right? So one of the images I was going to show, and actually I did show it briefly, the patient who had the different magnet strength and was a little blurrier on one versus on the other. When we did the other one, the previously called normal MRI, which I was like, I'm not sure about that, had a change called polymicrogyria. Again, you need to have the normal amounts of gyri, and this one was a little more erratic. Right? Instead of this nice up and down, peak and valley, there were areas that were kind of staticky. Right? Too many gyri. Very small, disorganized. And that was absolutely related to her seizures. And she did not have childhood absence epilepsy. So this was a patient who made sense to do the imaging on. But what was also found on her was an area in the front, and I'm doing it on my right, but it was the left, where there was an extra little fluid collection, a pocket of fluid called an arachnoid cyst. It was meaningless. It's not doing anything for her. It's not causing any problems. It doesn't cause seizures. Sometimes we find these in people with headaches, and people think that's the reason for the headache. Probably not. They just probably exist in a lot of people, and they don't cause any problem. But now people think, I have to do something about this in order to treat my headache, or maybe that's the cause of the seizures, and it's not. And so now this person gets a neurosurgery referral. Sometimes we do an MRI in a person and we find that there are small little dots, speckles, dittles in the white matter that are brighter than they should be. They could have been there their whole lives and probably have been there their whole lives. Because the truth of the matter is we are exposed to so much minor trauma in our life. And the birth process itself, even when everything goes right, is traumatic. So now we get this MRI in this patient who doesn't need it, and we find that there's white matter spots that I, as a physician, know are unimportant. Maybe at worst, I'll get one more MRI just to be sure that they're not changing and say, yeah, those really are chronic, have been there the whole life, don't need to do anything about them. But the family has to trust me on that. And hopefully they do. But I've had instances where they haven't, and they've been worried about what does this mean. We don't remember a birth trauma. We don't remember them hitting their heads. We don't remember any of these things, right? And they sometimes occur in people who have migraines, and they sometimes occur in perfectly healthy people. And now some people are worried about that. And it's because I did a study that really wasn't necessary. Again, most of the time, yes, you do need an MRI in epilepsy, but not every time. So the question of why is important, but should not get rid of the question of why not. And then if I know my why and why not, when and how. And most of the time we want the MRI so we can avoid the radiation risk. But like I said, there are some things we can see better on the CT scan. And then we just have to spend our time looking through it. And as a doctor, I may not know the neuroanatomy quite as well as the neuroradiologist or the neurosurgeon, but I assure you I know it better than the cardiologist, right? They know the heart anatomy better than I do. We all know our certain things. When I show the MRI to the family, it's quick. It's probably not enough time. But I also know that they're not going to walk out with years of medical training and all the understanding of the anatomy as is. I need to coach them and guide them through their child's epilepsy, and I want them to be informed and to understand as best as I can do. But I also have to spend time on wondering now, how are the seizures? Are you having side effects? What is this doing to you academically? How can we make your life better, right? And if having a finding means maybe I could take you to surgery, then I'm going to spend more time on that. If it means, yeah, we have this now, but it doesn't really change anything right now, we'll spend a little time on it, and then we're going to focus on the other things, because we have to focus on the whole child. The MRI is very important, and I want to get your guys' questions on it, and I'm now at that point. But really it comes down to understanding the anatomy, looking at the right and the left, finding the differences, and understanding that the MRI is not the end-all be-all. It is not the truth. It is just, or maybe not the whole truth. It is just what the computer calculates from a giant magnet. And then the doctor has got to figure out what to do with that. And it's got to coach you guys through it. All right, so that's my spiel. I got through like 2/3 of the slides. Let's go ahead and get your guys' questions. Mm-hmm.
There is a 3-dimension MRI as well?
Yes. So that's kind of what I was showing off a little bit with the 3D model of the brain I had there. That requires having really good thin slices and doing a lot of them so you cover the whole brain. But with that, you can make a 3-dimensional model of the brain. In fact, some people have taken that data and for fun, feeded it into a software to make a 3D printable brain. And personally, I kind of want to get an MRI just so I can do that. But I'm worried about what I will find. So when you are doing an evaluation for epilepsy surgery, we want a very high detailed 3D brain. Now, most people don't end up actually turning it into a 3D visualization. I do because I end up using it for our maps in epilepsy surgery and for a way that I process the EEG onto the MRI. But most of the time, what we're really talking about with that, where the benefit really is not so much in that 3D model as just being able to really see thinly the brain and each slice. Because if you have thick slices, you're going to miss detail, and you may not see the difference.
So if you've done studies, EEGs, and nothing definitive comes up, and
All right, so great question. If you've done studies like EEG and MRI and nothing definitive comes up, then what? And that is a difficult question. So the MRI is, even though I couch it as the MRI is not the whole truth and sometimes doesn't show you everything, that's not to say that it's not important. It's probably the most important test when it comes to epilepsy surgery. There are times where the MRI is really the thing that drives it, because we find where the seizures are coming from on the MRI. And there have been times where the EEG have said, oh, it's coming from somewhere else, and they try and go after that somewhere else, and it didn't stop the seizures. And then they went after the MRI lesion, and they found, yeah, that's what was doing it. The EEG can sometimes mislead us. So can the MRI, right? When an MRI is negative, and when we strongly believe that a patient has focal epilepsy, then we need to consider a few things. One, is it genetic? Right? So genetic epilepsies, many of them will have a negative MRI, not all, or a nonspecific MRI. But if I've sort of proven that this is a focal epilepsy, then what I kind of want to know is this a form of focal epilepsy that is genetic? Because if it's genetic and I have got a negative MRI, I'm probably not going to keep going with a surgical evaluation. All right? But if I have a negative MRI and I've done an EEG and they're definitely focal seizures, then surgery can still be an option. And that's important because I'm sure we all know medicines do not stop seizures in all patients. About 2/3 of patients are going to stop having seizures on medications and tolerate them, but about 1/3 don't. And so we have to consider other options, and surgery is one of them. So what can I do in that instance? Well, there's other imaging tests. As I said, the MRI is mostly structure, unless we do an fMRI, where there's a little bit of function there. But even then, that's looking mostly at normal function, at goals of where is language, where is motor, right? But what I want to know is, where is the seizure coming from? And that's where we have tests like PET scans and Spect scans, both of which are ways of looking at brain metabolism. The PET looks at how the brain uses sugar. Well, most of the time that's what PET's looking at. It again depends on what we actually give the patient. We give them a radioactive substance, most of the time it's sugar. But actually we can do different things for PET scans, and they do different substances for PET scans depending on the condition, because Alzheimer's, they might want a different substance than epilepsy. But what we're looking at then is how it uses that substance. And in epilepsy, the PET scan, the goal is, well, the area that causes seizures is not functioning right. So in between seizures, it doesn't use as much energy. So in between seizures, it doesn't need as much sugar. So we take that picture to look for areas that don't use as much sugar. The Spect scan is different, but similar. The idea of the Spect scan is that we're going to bring you in, and we're going to give you this radioactive substance right when you're having a seizure, as early as we can during a seizure. And what's that going to show us is how blood flow is going to the brain. And just like I said in the functional MRI, where an area that is currently in use needs more oxygen because it's more active, right? Because everywhere needs oxygen all the time. But if I'm being very active in this area here, it better have enough oxygen. Well, the seizure is hyperactivity. And so it's going to need more oxygen now, so it's going to need more blood flow right now. The trouble is, we're not only going to get one bright spot because the whole brain needs oxygen and needs blood flow. So what we'll actually do is another Spect scan when you're not seizing, and then overlap the two and use math and subtract it out. When you're not seizing, the rest of the blood flow is going everywhere it's supposed to go. And when you are seizing, it goes there, but more to the epilepsy area. So those just subtract away, and you just see the area causing seizures. When we use these things, we can still identify that this patient's seizures are indeed coming from, say, the right temporal lobe. And hey, that goes along with what we saw on our EEG. And that can be very important because that can help us say, this person is still a candidate for epilepsy surgery. So a negative MRI is only going to lead you to other steps and other considerations. It's not a complete end of the line, end of the journey. It's just part of the process. We want to have a patient have an MRI where we can find exactly where it's coming from. But even then, we can be confused. So there's going to be a presentation tomorrow at the continuing medical education course, right? The one for the physicians and doctors. And I'm going to be presenting a case. And long story short, there was a finding on the MRI that we would normally say, oh, that must be where the seizures are coming from, that was on the left, except all of our data said from the EEG that it was coming from the right. And we did a PET scan, and we did a Spect scan. The PET didn't help too much. The Spect scan pointed to the right, along with the EEG. And I did a special processing on the EEG, and it pointed to the right. And so what did? We did an investigative surgery, and we found out the seizures were coming from the right and not from the finding on the left. And that child is currently a month and a half seizure-free, when they were having 4 seizures a day before. So a negative MRI is not the end of the line, but a positive MRI is usually the most important test, but even then can be misleading. And as an EEG doctor, it's really hard for me to say, well, as an epilepsy doctor, but a lot of that is training on reading the EEG and how to correlate it to the patient's epilepsy. As an EEG doctor, it's very hard for me to say that the MRI is sometimes the most important test, but it really is true. If the MRI goes along with the type of seizures you're having, if the findings on the MRI go along with the type of seizures you're having, you have to take out the whole MRI finding, or the likelihood that you're going to make seizure freedom occur is very, very low. If you don't have a finding, that actually makes it harder to have seizure freedom, but there's still ways that we can try and do that. And so we want to make it available. And so it's just part of the process.
As they get older,
Mm-hmm.
we're talking about children.
Mm-hmm.
Do you repeat an MRI periodically?
I don't repeat it too often in most cases. There are some cases where I might. So if I had a person who had initially a negative MRI, but over time they became weak on one side, and they were having sort of continuous seizure on one side, I'd wonder if I'd see a process that was causing a progressive loss of brain tissue on the other side, right? And that has happened. There's a condition known as Rasmussen's encephalitis. It is an inflammation, typically of only one side of the brain. It's not an infection. And it's a process that starts with a couple seizures and then with like a continuous seizure activity and progressive weakness, and I see atrophy, and that comes. And for that patient, I'm going to want to have more MRIs than for a patient who has Dravet syndrome. Getting another MRI in a patient with Dravet syndrome actually isn't really going to change anything that I do for them, right? And it might, in some instances, make the family feel like, well, the doctor understands that I'm concerned about this because he did the MRI, and I wanted the MRI. But often I have to tell the family, there's not really a reason. If I get an MRI for you, you're going to continue to have seizures. I'm going to try and make that better with the medicines, right? So, or with VNS, or with ketogenic diet, right? But it's not going to be something that we can treat with surgery 98% of the time. So we don't need another MRI in the Dravet syndrome child, but in that Rasmussen encephalitis child, I do. In a child who had prolonged febrile seizures early on, and then later on developed epilepsy, I might consider repeating the MRI if it's been a long time, because over time you might see those hippocampal changes I mentioned about, that hippocampal sclerosis. All right? And in adult epilepsy, hippocampal sclerosis is very common. And in pediatric epilepsy, it's very common, but it's not as common because we also have so many other things. So the answer is, it is dependent upon the patient. And it really is dependent upon why I'm doing it, because if I'm thinking about epilepsy surgery, then I want to have a very recent MRI, or I want to know that the MRI was high enough quality. If I'm thinking about, is this a progressive illness, I want to see the state of progression. If, on the other hand, the patient has a chronic condition that I understand well, it's a genetics condition that we have enough data on, even if the child is progressively worse, that doesn't necessarily mean that an updated MRI is going to help me with that diagnosis or with that treatment. And then I just have to consider, am I going to have to sedate this child? And is it the right thing for this child? It's more commonly done repeatedly in conditions like multiple sclerosis. In multiple sclerosis, you're worried about new injury to the brain that happens by autoimmune attack. And that can happen at any time. And sometimes it can happen without an obvious symptom. And so for those cases, you'll probably end up doing every 6 months an MRI, right? But that's not something that we need in epilepsy most of the time.
Really small kids where they have like a cortical dysplasia, how valuable is it if you're considering for epilepsy surgery to do like a functional MRI where maybe your skills aren't developed and you don't know if you're taking away?
That's a very good question. So in a very small child, you have cortical dysplasia, and your concern is, I want to take that out, but am I going to make things worse? And so that's always the concern when you're doing epilepsy surgery, and that's why you're always doing everything that you can to not take out functional areas. If I was a 10-year-old and you took out my language area, I would not be able to deal with that, right? But a 2-year-old hasn't really wired their language completely. There's a lot of room left for it to move from one side to the other. And they can't necessarily participate in that language task. But some people have come up with passive tasks where maybe we're not asking the child to read something and come up with a verb. They wouldn't understand that, right? And these children have to be sedated because they're going to wiggle and move. But where they actually will play a recording of the mother's voice. Now that's going to activate primary hearing regions, but it's also going to activate potentially understanding regions. And as a result, you get sort of a language understanding from there. Now, like I said, that can rewire. And the younger you are, the better that can rewire. Motor doesn't rewire as well. Motor really needs to be good and intact. And now the earlier you do it, okay, there's still some capability, but you're going to have a difference. And so we want to know about that. But most of the time, the dysplasia is not in a functioning area. Most of the time, the dysplasia actually is dysfunctional and working wrong and causing disruption of other areas. So most of the time, if you take the dysplasia out, you probably won't have to worry about the function. Nonetheless, we do a lot of testing for each patient because we're not just going to say, it'll be fine, right? We're talking about brain surgery. We're talking about this person's life and about wanting to make that life better. And so we're going to do just as much testing as necessary to make it as safe as possible and to know as best as possible what the likely outcomes will be. Because we want to be able to tell that to families. And we can never give 100% guarantees, but we want them to have as good of counseling as possible. So if we're going to move there, we're going to find some way to test that function as best as we can. No, although it might be notable to say that sometimes with the dysplasias, if you get it at, say, 6 months of age and you get that MRI, like I said, there's that white matter that's changing over time. And the MRI doesn't look the same for a newborn to a 6-month-old to a 1-year-old to a 2-year-old. And it might be that if you got it at 1 month, you'd see the dysplasia. At 6 months, you won't. And at 2 years, you will again because of this process of how the white matter is changing. So the MRI in the interim could actually make it harder to find all the borders of the area, and that's where doing the recording is going to be very important.